Well, welcome back from lunch, everyone. And now we'll start the afternoon of day one. And my job is simple here. I want to welcome Dr. Atul Gawande from the Brigham and Women's Hospital. And he's going to talk to us about Cowboys versus pit crews. Dr. Gawande.
Thank you, Joe, and thank you for the chance to talk to you this afternoon. I want to talk to you about the idea that, and if this isn't working, I'll wander a bit. I want to talk to you about the idea of that ties together what I've been doing in writing and in research, which has been rooted in something that seems very simple, which is it stems from the fact that I'm not actually an expert at anything. I started writing as a resident in surgery. And I never claimed to try to know anything more than the colleagues trying to teach me. But what I was focused on was trying to understand how I might get good at what I do in medicine. And what I found is that by trying to think out loud about this, that a lot of other people were trying to ask themselves the same question. That we were all wondering, how is it that we get good at what we do in medicine as a whole? And the answers have not turned out to be in the textbooks. We don't find answers in there like, how do you deal with failures? Or what do you do when you have to depend on other people who don't necessarily do their job? The question has gotten harder in the last few years because of a problem that has always been lingering but now has reached crisis proportions, which is, what do we do about the cost of healthcare as well? So now we're trying to understand how we get good at what we do in medicine, how we might even be great at what we do in medicine for patients, while coping with the fact that it also is bankrupting them. In the last decade, there was a report that just came out this past month in the newspaper, which has echoed ones that have been coming out for a while. And it showed that for the winners in our society, the median family of four who've actually had insurance for the last 10 years and had employment, that their incomes, in fact, did rose about $23,000 from 1999 to 2009. But virtually every dollar, all but $95 a month, ended up going to paying the increasing costs of their health care. That story has been echoed at every level through society. In Massachusetts here, there was a report not too long ago showing that every dollar we had spent, and we had spent many tens of millions of dollars on school reform, on trying to improve our public schools. And every dollar, it turned out, that we had put into school reform had ended up being diverted to paying for the increasing costs of the health benefits of teachers, even as their coverage for health insurance has been cut along the way. What we're finding is that the cost of healthcare is destroying our future and destroying the American dream. Now, what's the cause of this? We've had a political debate that has focused on the problem is the government and too much regulation, or the problem is the market and too much treating medicine like a business. And the reality is that both have made our jobs as clinicians harder, but they have not been the cause of the difficulty. They've instead been a symptom of the problem, and the problem we face is the complexity of medicine, the increasing volume of knowledge and capability that we're trying to deliver on. Lewis Thomas, a physician and writer who's a hero of mine, wrote a book called The Youngest Science. And in it, he had a chapter describing what it was like when he was an intern arriving at Boston City Hospital in 1937 in the pre-penicillin era. And what he described was a world where medicine was cheap but ineffective. He said, if being in a hospital made a difference, it was mostly the difference produced by warmth, shelter, and food, and attentive, friendly care, and the matchless skill of the nurses in providing these things. Whether you survived or not depended on the natural history of the disease itself. Medicine made little or no difference. That didn't stop the doctors from being frantically busy, nonetheless. Mostly, he said, what they tried to do was make absolutely sure that they did not miss the handful of diagnoses that patients could have where the doctors could make a big difference. There were a few of these. Lobar pneumonia, at that time, the residents could treat with a rabbit antiserum. Congestive heart failure and acute heart failure, they treated by bleeding a pint of blood from an arm vein, giving the patient a crude preparation of digitalis leaf extract, and giving the patient some oxygen by a tent. A patient with early paralysis who you could figure out that it was coming from syphilis, you had the option of being able to give them a nice little combination of arsenic and mercury. And that was pretty much it. Now, 3 generations later, look at where we are. Look at what science has given us. We've identified 13,600 different ways that the human body can fail. 13,600 diagnoses. How do I know that? Pick up your ICD-9 procedure billing code book, and it enumerates every diagnosis that has been found, and in fact, it lumps together many of the diagnoses. And for all of those diagnoses, we've found ways to actually help people. If not cure them of disease, then reduce their suffering, improve the quality of their lives. But that capability has required now 6,000 drugs and growing, more than 4,000 medical and surgical procedures, and hundreds of known steps that can help prevent their disease. And what we're trying to do is deploy that capability town by town to every person alive. And guess what? It's turning out to be pretty hard. This is, I would argue, man's most ambitious endeavor. There is no industry that has to deliver on 13,600 service lines in every community in the country without regard to people's ability to pay, yet do it in a field with the kind of complexity that we face on top of that. Our patients, for example, don't ever come with just one of these diagnoses. For the 5% of patients who account for 50% of our healthcare costs, those patients typically come with many of these problems piled in together. What we've reached is a point where the knowledge and capability has exceeded our individual capacities to master it as clinicians. We can't do it by ourselves anymore. We can't hold all the knowledge in our heads and be able to make everything that needs to happen for people. One of my colleagues at Johns Hopkins had looked at their hospital to understand in 1970 how many clinicians were required to take care of a patient, and the answer was just over 2 clinicians on average, usually a doctor and a nurse. Then they looked in the 1980s, late 1990s actually, at how many clinicians were required for the care of patients with the same conditions. And the answer was, it was more than 15 on average. Now, we built our health system and the way we go about our work in medicine in a world where it looked much more like that picture from 1970. A couple people could get it done. And what you valued the most was autonomy for those people, giving them the chance to express their own judgment, their own take on what might work and what might not work. And it worked pretty well. But when you have 15 people, each of whom are taking their own view of events, their own sense of what needs to be done, and they're only doing part of the job, and they don't actually point in the same direction, autonomy, as our highest value, means chaos. We've built our system for cowboys. That is, we train, hire, and reward people for being cowboys, for valuing their judgment individually above all, when what we need are pit crews for patients, groups of people who are able to point in the same direction for the benefit of the patient and work together as teams to make things work well. The signs that this is not what we have can be reflected in some basic kinds of numbers that we see regularly. For example, that 40% of our coronary artery disease patients in our communities receive incomplete or inappropriate care, that 60% of our pneumonia, asthma, stroke patients receive incomplete or inappropriate care. And we also see it in our cost explosion. I think we in medicine have mostly been baffled by the discussion about costs and to some extent about quality as well. We mostly want to say, look, we're working hard, and this is just the way good medicine is. An aspirin for arthritis was all we had before, and now we can do a $50,000 hip replacement that makes it possible for people to have far better lives, continue to work, even live longer than they ever used to do before. And that's just the way medicine is. But we'd be ignoring certain things if we take that as our only lesson. There is a bell curve in medicine, a bell curve for the results that we get depending on where you go for your care. And there is a bell curve for cost depending on where you go for your care. And here's the striking thing. The two curves do not match. That is to say, the places that get the best results are not the most expensive places in the country. They are often in the middle or even among some of the least expensive places in the country. And what that means to me is there is hope. Because if the only way you got the best results was by spending the most money, then we'd be doomed. The only choice we would have would be to ration, to decide who's going to get cut off from that capability. But the idea that there are positive outliers, positive deviants, who get higher quality than other people, but at lower cost, means there is something important to discover. And when we have looked closely to see what is happening at that upper end, at that positive deviance end of the spectrum, what we're finding is that those places that function most like a system are the most successful. By system, I mean that the components and parts of care are actually meshed together. It's a pit crew, or it's like a car where all the parts fit together. We in medicine have been obsessed mostly with components. We want the best drugs, the best devices, the best specialists for care. But we thought very little about how to make them all fit together. You can imagine building a car this way. You could even do a randomized trial, and it might tell you that the Porsche engine is the best engine, and Ferrari brakes are the best brakes, and a Volvo body is the best body, and a BMW chassis is the best chassis. But put it all together, and what do you get? A very expensive pile of junk that does not go anywhere. And sometimes isn't that what medicine feels like? Now, those places that have the parts begin to come together and nowhere has gotten it working smoothly. Those places that begin to get the parts fitting together start to look like systems because they have certain skills that they are putting together. And those skills are the ones that are going to be fundamental, I think, in this next decade of work coming up. The first skill is the ability to recognize failure and success, the ability to know whether your program is doing better this year than it did last year. And it's often very specific kinds of things. A surgeon who is a colleague in Cedar Rapids wanted to know how many CT scans were done in their community the year before because of the reports that there's a ton of CT scans apparently being done, and he didn't quite believe it. Took him more than 4 months of work and having to hire someone to really drill down to find the numbers for their community of 300,000 people, because there are 3 hospitals and there's outpatient imaging centers and all that kind of work. And it was impossible to see where they stood. Finally, though, they did get the answer. And they discovered they had done 52,000 CT scans in 1 year for their population of 300,000 patients. And he knew it was wrong. And he also knew that this is just like all of our communities, because we've known that there are 70 million CT scans that are done per year and growing for our population of 300 million, but making it meaningful at the local level is where we need to have our ability to measure. The second skill is then having measured, having found key problems like this, you have to be able to innovate solutions. Design of solutions is underestimated. Our problem is that finding solutions means not just a magic bullet. It almost always is that multiple things have to be made to go well together in order for a great result, an improvement to come out of it. In surgery, when we were faced with this question of how we might improve results in surgery, it became extremely clear. It was not just a problem of preventing infection, but making sure bleeding was well managed, and that the anesthesia teams knew what they were doing, and that the surgeons had plans that were communicated with everybody else. And so we decided to take an approach from aviation for how to do that, which was to use a checklist. The process of making something as simple as a checklist turned out to be much more difficult than we understood. We had to test, we had to redesign, we had to move along with putting it all together. But the result was a 2-minute checklist that we found when we implemented in 8 hospitals around the world, cut complications in every hospital, an average of more than 35%. We cut deaths more than 47%. And now we've moved this work onward to finding what is the checklist that is the set of things we'll do differently next week in childbirth, in care of the terminally ill. And that's where we come to our third difficulty, implementing, being able to implement at scale. Last week I wrote in the New Yorker about the concept of coaching, which really came out of a puzzling over how we take ideas like this and bring them into practice. Places have found it hard. And as we carried out a program to bring our checklist work to every hospital in South Carolina, we found we were actually needing to do coaching. That is, being in their operating rooms, giving them feedback on the spot in a way that we just don't do in medicine. We've assumed that you are simply taught, you're licensed, and then you go. But making teams work together has turned out to need an entirely different concept from the beginning. As we unfurl these ideas, we have recognized that we are overwhelmed with all the things that we end up having to fix in our system. And that brings us to the fourth skill that we have to sustain, the ability to prioritize. We are overwhelmed with projects that we could carry out like these. And in order to choose which ones to focus in on, I would argue we would want to focus in on those handful of projects that help the 5% who account for the 50% of healthcare costs. Because almost invariably, they're getting the worst, most uncoordinated care. We know they have the highest costs. And if we solve their problems as the first priority, this is going to be the way we can not only improve care and safety, but also help reduce our overall costs. What we're trying to come together to do is not checklists. That, I hope, is just the beginning of making ourselves into pit crews for patients. It's coaching and checklists and information technology and measures. It's all the ideas that we need to reach a point where we are tuning and tweaking our performance for the better and better aid and comfort of human beings without waste of resources. What's needed as we move along is the first community to actually lower healthcare costs without rationing and to prove that they did it. All of you here, I think, are here because you have skills and interests in being able to do that. I think you can work to add one of those 4 skills to your community. And when you do it, you will be bringing something that I feel is sorely needed: hope. We have lost hope as a society that we can fix major problems of these kinds of ambitions. I think we have a decade. It isn't that we have to reduce healthcare costs within 2 years, but if we can prove as a profession that we can do so in this next decade, we will have saved our society. Thank you.